Today we're going to review a video of our surgical management of a parasitic fibroid within the space of Retzius. Parasitic fibroids account for less than 1% of all fibroids. They arise either by auto-amputation of a pedunculated fibroid or through tissue dissemination at the time of surgery. Such fibroids have been found in a variety of anatomic locations, and symptomatology and potential complications vary with these locations. Our patient is a 47-year-old G0 female presenting with lower urinary tract symptoms and pelvic discomfort. Medical management had been ineffective. She had undergone a minimally invasive hysterectomy for fibroids 8 years prior. Pelvic sonography demonstrated the presence of a 4-centimeter smooth mass in close proximity to the proximal urethra. Pelvic MRI localized the mass as anterior and inferior to the bladder, with an appearance consistent with a parasitic fibroid. After laparoscopic access to the abdomen and pelvis was obtained, the pelvis was inspected and a rounded, smooth, and firm mass was noted anterior to the vaginal vault. The Foley catheter balloon can be seen to the right of the mass. A ring forceps is seen within the vaginal vault, below the level of the mass. Given the proximity between the bladder and the mass, methylene blue was instilled into the bladder to ascertain its location. Upon instillation of methylene blue, the mass was no longer recognizable transperitoneally, suggesting that the bladder was juxtaposed anteriorly to the mass as suggested by MRI findings. We then performed cystoscopy to ensure that the bladder was free of any lesions. Both ureteric orifices were appropriately visualized. The bladder was indented by the mass extrinsically, however, there was no evidence of the mass having any intracystic components. In order to gain access to the mass, the space of Retzius was opened using the CO2 laser by incising between the medial umbilical ligaments. Dissection between the medial umbilical ligaments ensures avoidance of the inferior epigastric vessels. The borders of the space of Retzius are the parietal peritoneum superiorly, the symphysis pubis anteriorly, the arcus tendineus fascia pelvis laterally, the bladder posteriorly, and the proximal urethra and bladder neck inferiorly. The preperitoneal adipose tissue was dissected while the bladder was insufflated with CO2 in order to localize the dome. The dissection was carried down to the level of the pubic rami, and the iliopectineal ligaments were exposed bilaterally. The mass was then identified within this space anterior to the bladder dome. The mass was subsequently dissected out of the underlying tissue using a combination of carbon dioxide laser dissection and bipolar cautery. Hemostasis was assured within the defect. Cystosufflation was once again performed in order to both delineate the outline of the bladder as well as ensure that there were no defects within the bladder. The bladder was found to be intact. Once the mass was removed, the incision into the space of Retzius was closed. We recommend a monofilament suture such as 2O Maxon to achieve this closure. The suture was secured extracorporeally using a rotor knot, which was subsequently pushed intracorporeally using a knot pusher. The patient was discharged home on postoperative day 0 after a successful voiding trial. She recovered well. At her postoperative visit, she reported significant improvement in her lower urinary tract symptoms. To sum up, parasitic fibroids should be considered in the differential diagnosis for pelvic masses. Surgical management may require involvement by multiple surgical specialties, however, can result in a significant relief in patient symptoms.